very much, Jesus. Actually, you're giving me some argument because as a transplanter, I have been always very consistent in my opinion, which is yes. So it's a debate, and well, obviously, we know very well that we're not certain that we'll settle this question today, but it's always better to debate a question without settling it than to settle it without debate. Of course, you know what Voltaire said, a long dispute means both parties are wrong. So I'll try to keep on time, although we are already late. So can I win this debate? Obviously, I must confess no, because I'm debating against the king of myeloma. And yesterday, I think Philippe mentioned how the young fellows we were in 1998 or 97, impressed by these Blade EBMT criteria, like, you know, the famous guy we would like to touch. Because at this time, remember, I was doing this, roughly. But having been in a boarding school since my younger age, I have been always taught that you should never yield to the apparently overwhelming might of the enemy. And at the end of the day, even if I cannot convince you, I'll try to confuse you, and then you'll think about it. Okay, why do we need to do transplant in the elderly? Well, obviously, we have been praising the results in the young population since now many years. And we are very proud of the result achieved with total therapy, with the IFM 2009. So why don't we extrapolate this to the elderly? Also, this age limit of 65 has no biological background. Can someone show me any evidence what's the difference between age 64 and age 67? No one. It was mainly due to the retirement age in many countries in the 80s and 90s, and we thought that when you retire, you get old. Also, I mean, Joan himself retired, but he's telling me he continues to work, and he works Tuesday, Wednesday, and Thursday. The initial era of auto-transplant, and Philippe also very nicely highlighted this, was mainly using bone marrow grafts, so delayed engraftment, infectious complications, higher toxicity. So obviously you don't want to give this to a 72-year-old gentleman. The good news, I must confess, that by having a good threshold, a unique threshold, you can compare trials. I want to be also reasonable. The goal is not to transplant everybody. I think we are reasonable guys in this room, and the idea is to select the patient. And we know that the elderly patient are not all the same. So my focus is to say, well, if you are an elderly 74, 75, and fit, definitely, you need to go to transplant. And of course, yesterday, Dr. LaRocca tried to convince us that you have the tools to detect these fit patients. This is a typical case we had some time ago, 71-year-old gentleman. He has some diabetes, but you know, everybody these days has got some overweight, diabetes, hypertension, very common. Depression, okay, because he was a war veteran, actually. He went to the emergency department because of the low back pain, frequent urination, fatigue, lethargy. You could guess this is myeloma, hypercalcemia. He works actually part-time because more and more people continue to be active. So I want to see whether you are convinced or not, and then I'll stop if you're not convinced. Is this patient a suitable candidate for transplant? Just raise hands. Oh, bloody, you'll have a hard task.
Even biology says that.
So I think they are convinced, Joan. Be careful. So, okay, why are we worried about transplant in the elderly? Because age correlates with comorbidities. But let me show you the impact of comorbidities on the outcome of transplant. There is this modified Charlson comorbidity score adapted to transplantation. I will not go through the details, but the CIBMTR looked into a very large series about the impact of these comorbidities on transplant-related mortality, because this is our concern in an elderly population. And I'll focus on the 11,000 plus auto-transplant patients. This is rather a decent evaluation. This is a prospective evaluation, by the way. So the important information, and this is quite logical, is that your transplant-related mortality is going to increase with comorbidities. So if you have more than 5 comorbidities, or more than 5 as a score for comorbidities, your transplant-related mortality is going to be increased. But please don't forget, we are going from a baseline, which is usually transplant-related mortality of autotransplant is less than 1%. So you are less than 1%, and in the worst scenario, you're not even reaching 2. So still, a relatively very safe treatment approach. So the fear about comorbidities is not really relevant. Then we are concerned about transplant complications without killing the patient, let's say. So what are these transplant complications? It has been studied. Actually, in the initial period, it is mainly about fatigue, psychological distress, and GI toxicities, melphalan, mucositis, diarrhea. Everybody has seen this when you do the round. This is the main complaint about the patient. I must confess, there's no magic solution for the moment about this, but still, in the non-transplant treatments like Lendex, 40% of the patient complain about fatigue, and they complain about it for many years, not only for two weeks. Psychological distress, it's universal. It's relevant. Kartik, I think, highlighted this nicely. When you have myeloma, obviously, you have psychological distress. GI toxicities, actually, yesterday, Dr. Plessner highlighted the issue of diarrhea with IMiDs, with bortezomib. So nothing specific. The only good news is that with transplant, it's focused, it's concentrated on the initial era. So age per se, in my opinion, is not a contraindication for autotransplant. And actually, we already knew this from the pioneers. So, when I was at the primary school, Bart published this nice paper showing that he was always a visionary guy. Over 65, actually, the numbers were relatively small, but he could show that he can deliver his intensive therapy to a relatively old patient with good results. What can we glean from the literature? Actually, this is not comprehensive, because otherwise it would take me hours. But then, if you look in the most recent era, last 10 years, this is the last one I've seen publication, multi-center retrospective from Israel. Actually, most of these studies, of course, you can debate about the dosage of melphalan, but at the end of the day, all of these studies didn't really show a specific difference between more or less young or old patient. Probably because as physicians, we are rather good in selecting the fit patient. And actually, whether we're debating or not, the reality is that it has been now more and more used. This is the EBMT data. This is from 2012, but when I looked recently, I didn't update it. Actually, 25% of the transplant activity is above age 65. So the people are using it. When you look in a prospective multi-centers, this is 5 or 6 French centers. When you look to the shape of these figures, actually, these are patients between age 65 and 75 who got VCD, VTD, or VTD, auto and consolidation. Actually, nothing different compared to the younger population. Also, more and more, it's becoming, I think, justified, and we heard the issue of cost a few minutes ago, to consider, in my opinion, autotransplant, because the drugs, they are magic, excellent, wonderful, we are very proud of them, but, so this is a table that is going to be published in a couple of weeks in the ASCO educational book by Vince Rajkumar. And look at these numbers. They are really impressive. And this is single agent. So in the book, the second part of the table, he is giving you the price of the combination. And you can easily guess the price of DARA KRD, for example. But just looking, to RD or, VRD, you would easily guess, for us, at least in this country, for example, the reimbursement for an auto-transplant is $25,000. So 23,000 euro, I guess, $25,000. So age alone, my conclusion, is not sufficient to define treatment approaches. I hope you're convinced, Joan, because myeloma is characterized by successive relapses with decreasing remission duration. And the first remission is likely to be the most important, especially if you are age 70 or 72 or 75, because this is the most important treatment period. So you have to win from the beginning. You have to achieve this from the first remission. Of course, for the sake of time, I will not debate whether risk factors may allow to identify low risk, high risk, intermediate risk, and say we'll do this for this. But I hope I managed to convince you that this is really a relevant option. And of course, there's nothing bad in this debate, Joan. We are friends forever. Thank you very much.
Now is the turn of Dr. Blade, that is still working Tuesday, Wednesday, and Thursday, and even working Friday, Saturday, Sunday, and Monday on the Canary.
and at the meetings also. Good afternoon. Since I was a child, with a debate or a competition, I also like to win. And I thought, hot debate with Mohamad, I will be the winner. But then I realized that he's inviting me every year at the COMy meeting in Paris, my honeymoon city. And I thought, I will be moderate. And then I saw the program. You see the program book here, but here, you see. And I said, oh, I also want to see you next year. So I cannot go deeply, and I will make some compliments only on the speech. So these are my disclosures. For young patients, a refined total therapy is the goal in order to increase the cure fraction. Autologous stem cell transplant is superior to conventional chemotherapy and also is superior to treatment with novel agents in terms of complete remission rate, progression-free survival, and in some trials, overall survival. Operational cure in multiple myeloma can be perhaps defined with continued CR at 10 years post-therapy. Dr. Barloghi told us 10, 15. In autologous transplant, this is achieved with all drugs in about 10% of the patients. Hopefully, will be increased with the novel agents. And in fact, I mentioned the other day, on Friday, that BTD autologous transplant 3-year maintenance, in this arm, we have now an estimated progression-free survival at 10 years of 26%. And with conventional chemotherapy, the cure rate with all drugs is less than 1%. And we don't know, we don't have enough follow-up for determining the curability of myeloma with the incorporation of novel drugs. Concerning patients who achieve CR with autologous transplant, 30% of them remain progression-free survival at 10 years, and no relapses were seen in the Spanish registry study published 7 years ago. So autologous transplant is the standard of care for patients younger than 65 years. So the treatment would say the European total therapy consists for younger patients in a triple induction regimen, likely 6 cycles, proteasome inhibitor, IMiD and DEX, high-dose therapy, consolidation, maintenance with lenalidomide-based regimen, along with DEX, with proteasome inhibitors, and the future, as above, incorporating monoclonal antibodies, particularly DARA, at induction, consolidation, and maintenance. So, what determines the transplant ineligibility? This is the frailty, not the age per se. The age is associated with comorbidities, and the comorbidities are those limiting the indication or the eligibility for transplant. Clinical trial design. Why the 65 years limit for autologous transplant? This is only to be in the safer size in order that they avoid the inclusion of patients with comorbidities for anxious investigators trying to have more patients included in trials. Mohamad just showed you this slide from Dr. David Siegel when he was with Dr. Barloghi in Arkansas almost 20 years ago, and he showed no differences with all drugs, but you can see that the progression-free survival is not significantly different, but is only 1.5 years for patients older than 65. He didn't mention this. Also, the Mayo Clinic reported the outcome of patients elderly versus young. Young is defined less than 65. Elderly is defined more than 70. Perhaps Jean-Luc is
Still young.
Yes, still young, but no, you are not young, perhaps not elderly, because I am not in these groups. I am not young, I am not elderly. I am, and I don't know where I am. Perhaps you could ask my wife. And then, gray zone. So, no significant differences in progression-free overall survival in the Mayo studies. And this is a large, very interesting registry study by the IBMTR in the US. Almost 12,000 patients included from 2008 to 2011. And you can see that the overall survival, adjusted probability of survival, is decreasing by increasing age, particularly in patients older than 70. There are no differences in progression-free survival, but the number of patients is much lower. In this study from the IBMTR registry, there were among almost 12,000, only 146 patients aged 75 to 79. 60% of them received less than melphalan 200, and the 2-year survival was 91%. But interestingly, there were 8 patients older than 80, so only 8 among 12,000. And it's much better to be over over 80, because the 2-year survival rate is 100%. This means, obviously, a careful patient selection. Yeah? But 10 years ago, our friend published that in patients over the age of 65, autologous transplant, too many autologous were equal to melphalan-prednisone and inferior to melphalan-prednisone thalidomide. Probably the design was wrong with these two minis. But, okay, so our friends showed this. And more recently, in Hematologica, in patients younger than 65, included in the IFN trials, those who were age 60 to 75 did worse than those younger than 60. So age, if there is no a bias selection, great bias selection may play a role here. And you can see here the overall survival by age between 60 and 65 and younger than 60. We have performed about 300 transplants at our institution, and you can see that only 10% of the transplants in our institution are older than 65. So this also means patient selection, not in trials. You can see that the response rate is slightly better in younger patients, but the median progression-free survival, when you select the patients, is not different. Dr. Barloghi will be pleased to see this follow-up longer than 20 years. And concerning median overall survival, we can see that it's very similar when you select. Who and when should decide on the autologous transplant in the elderly? The hematologist, the oncologist, perhaps much better the bone marrow transplant team and the hematologist or oncologist in agreement. At diagnosis, if you don't use melphalan, it is not so important. If we use melphalan, you should have a clear idea, because this can prevent the obtention of stem cells. And during or after induction, we can decide this if you, for example, use BRD or similar regimen. So, if I was Mohamad, I have said in favor, please don't miss the opportunity to deliver high-dose melphalan in very fit elderly. As I am in the other side, I say only very fit elderly patients with multiple myeloma can benefit from high-dose melphalan. And as I am partially retired, only partially, Renault realized and were aware, and just this morning, I have signed the contract part-time with Renault at the Champs-Élysées in Paris. Thank you very much.